So good morning, everyone. So we had a new grand rounds today. So we had a very special speaker. We had Dr. Pardo. He's a professor of neurology and pathology at Johns Hopkins University School of Medicine. He focuses on studies dedicated to the diagnosis and management of neurological, neuroimmune, and neuroinfectious disorders. As a clinician, he's dedicated to studies on neuroimmunological and neuroinfectious disorders, and he serves as director of the Johns Hopkins Myelitis and Myelopathy Center, unique specialized center dedicated to clinical and research of spinal cord disorders. He collaborates extensively with different groups around the world and is currently the PI of neuroviruses emerging in the Americas study, a NH4 Center funded multi-center study based in Colombia to investigate the role of emerging viral infections in association with neuroinflammatory disorders such as encephalitis, myelitis, and Guillain-Barré syndrome. He's the PI of the acute flaccid myelitis natural history study funded by the NIH to characterize the natural history of such disorder. As a neuroscientist, he research centered on studies of immunopathogenic mechanisms of neurological disorders, animal models of and biomarkers for disease. His studies on immunopathogenesis and biomarkers discover use of state-of-the-art immunological and molecular techniques to investigate brain tissue and cerebrospinal fluid and blood. I had to mention also Dr. Pardo is, I mean, you can think Colombian as me, and I had to say that also he's from a region that my father also from, so I had like some expectation for him is like some kind of like familiarity. So I'm very happy that he's coming to us and to be able to do this lecture. So Dr. Pardo, all the spotlights to you and the microphone. Thank you so much for coming as well.
Thank you so much, Sergio, for the invitation, and thank you everybody for being present here. Very sure that as happening in many of our hospitals, early morning, 9 o'clock is busy for everybody, but I hope that in the next 45, 50 minutes, we can cover a good discussion about the topic of myelitis and myelopathies. And I have dedicated the last 20 years of my professional life to focusing this topic, and I hope that the experience that we have acquired translate in some improvement and actually help for many of the patients that you are going to encounter with spinal cord disorders. I don't have any commercial disclosure here. My research support is coming from National Institute of Health, but also I have the great support from philanthropy, the Johns Hopkins Project Restore, the Barr McLean Fund for Neuroimmunology Research, and actually a large support from the Siegel Rare Neuroimmunological Association, that is a patient and parent association focused on rare neuroimmunological disorders, including myelitis and myelopathies. What I'm going to show you is basically the experience that we have accumulated in the past 20 years at the Johns Hopkins Transfer Myelitis Center that was named Transfer Myelitis Center until 2019. And currently, we actually modified the name to the Johns Hopkins Myelitis and Myelopathy Center. And actually, the reason we modified the name is precisely one of the main focus of this lecture is we like to make sure that the term transient myelitis goes away and we have a more precise diagnosis of spinal cord disorders and myelopathies. So the educational objectives of this lecture is to understand the concepts that define myelitis versus myelopathy. And as you can see from that, goal is mostly to establish etiological diagnosis rather than introducing a name that in many ways is not going to help us too much, as I'm going to show you in the next few minutes. Because this is a lecture that is focused on education and particularly focused on the residents and fellows. I'd like to discuss the diagnostic approach to characterize acute myelopathies and myelitis and review the evolving concepts of those disorders. But at the end, the final goal that I'd like to achieve today and bear with me, is I like to make sure that you get the message. Stop using the term transient myelitis and move to a better definition of etiological diagnosis in spinal cord disorders. I think that the use of the term transient myelitis is hurting a lot of patients, and unfortunately is introducing a lot of unneeded therapies to those patients that are unfortunately misdiagnosed with the term transient myelitis, and many clinicians in the community and other health providers actually are assuming that many of these disorders are immunological mediated disorders. So where is this term coming from? Back in the 19th century, at the end of the 19th century and the early 20th century, many of the disorders that were characterized in the spinal cord from the pathology point of view and clinical point of view defined spinal cord disorders associated with infectious pathologies. And it was very frequent, particularly at the beginning of the 20th century, that there were many viral disorders and many bacterial disorders that end up producing a spinal cord involvement in form of inflammation of the spinal cord. And many times the terminology used at that, during that period was infectious myelitis. However, the term transient myelitis was introduced at the end of the 40s in a paper that was describing a patient with an upper respiratory infection that ended up having a myelopathy few days after the upper respiratory infections. And the term transient myelitis was introduced in a case report that was published in Lancet. And since then, actually, the term transient myelitis became popular and has been used in many cases, in many instances, as a description of spinal cord disorders associated with inflammation. So unfortunately, as we are going to see in the next few minutes, not everything that affects the spinal cord is an inflammation. Not everything that affects the spinal cord is an infection. And many times, actually, the clinicians need to be aware about those distinctions and etiologies. Now, let's go back 20 years ago. At the beginning of the 21st century, the spectrum of spinal cord disorders that were labeled myelitis was centered around the diagnosis of multiple sclerosis. And many of us who were educated in the 20th century, in the 80s or 90s, or even early 21st century, we encountered many cases of inflammation at the spinal cord, and many of these patients actually went to the basket of the clinical diagnosis of multiple sclerosis. And obviously, we pay attention to infections, we pay attention to rheumatological disorders as a potential cause of myelitis. And we had a disease that was called at that time in the 20th century, the VIX disease, that basically comprised a large group of patients with spinal cord disorders and optic neuritis that during that period actually were not really well explained. And many of those patients actually were misdiagnosed as multiple sclerosis and received treatment as multiple sclerosis. However, the major revolution in the understanding of myelitis came around the first part of the 21st century, around 2005, when our colleagues at the Mayo Clinic identified an antibody that was associated with that disorder that was called the VIX syndrome or the VIX disease. And later, this became clearly the first inflammatory myelopathy or myelitis that was associated with an autoimmune disorder in which there was clearly presence of an immune-mediated mechanism. So this finding actually was a very important finding, and it revolutionized the understanding of myelopathies, particularly because explained very well the presence of a form of inflammation of the spinal cord that was very different to multiple sclerosis in the sense that the topography was very particular, affecting several segments of the spinal cord in contrast with multiple sclerosis that was predominantly multifocal and small lesions in the spinal cord. And this form of longitudinal extensive myelopathy was later identified to be one of the main characteristics of neuromyelitis optica. Now, the second element that is very interesting is that this form of myelopathy was frequently associated with optic neuritis that, again, was very different to the optic neuritis in MS because appeared to be frequently bilateral and appeared to be frequently longitudinal extensive as well. And many of these patients with neuromyelitis optica basically didn't have the spectrum of changes that we see classically in multiple sclerosis. So this, again, is one of the major events in the understanding of myelopathies and autoimmune myelopathies, the finding of aquaporin 4 antibodies that define the cause and etiology of neuromyelitis optica. Now, the second finding in the past 20 years that actually has changed dramatically our understanding of myelopathies is the rediscovery of myelin oligodendrocyte glycoprotein as a pathogenic element in the etiology of some form of myelitis. And this is important because MOG was very well known since the 80s and 90s because MOG was the model that was used in many of the animal models for multiple sclerosis. That was basically the protein that was used for inducing encephalomyelitis in mice, and actually it was very well known. However, approximately 10 years ago, this factor was demonstrated to be an important factor, and MOG antibody-associated disorders emerged as one of the important causes of autoimmune pathology in myelopathies. And it's very clear now, as you know well now, that MOG is frequently a disorder that may show up during childhood and adulthood, and produce also a clinical profile that is very different to multiple sclerosis. And even the radiological MRI approach is going to show that is very different from the spectrum of disease that we recognize in demyelinating disorders. I am not going to extend too much my discussion about NMO or MOG because I believe that in your practice you have been very well exposed to those two disorders. But let me show you what is the current understanding of myelopathies and myelitis. As you can see, I am using two different terms, myelitis and myelopathies. And this is because in the past several years, we have encountered that when we pay attention to a very precise clinical characterization of spinal cord disorders suspected to be associated with myelitis, it's very clear that the majority of them are associated with inflammation, but there is a subset of spinal cord disorders in which there is no evidence of inflammation based on spinal fluid analysis or magnetic resonance imaging. And that is what I'd like to take you to examine in the next few minutes, taking in account the acuteness of the symptoms and the temporal profile in the onset of those symptoms. So the most important group, as I mentioned in the past few minutes, the most important group of inflammatory myelopathies that we have characterized in the past 20 years is the group of autoimmune associated inflammatory myelopathies. These autoimmune associated myelopathies are frequently in the spectrum of neuromyelitis optica, in which aquaporin 4 antibody is the main culprit, or is myelin oligodendrocyte glycoprotein, or are groups of other myelopathies, such as those associated with Sjogren disease, or those associated with lupus, or other autoimmune disorders that produce important spinal cord damage that evolve in an acute or subacute pattern. Now, the second group of disorders that have emerged in the past 20 years is a group of disorders that are clearly associated with infectious factors. And perhaps the most important one is acute flaccid myelitis, that is predominantly a myelitis that affects children that behave as a polio-like disorder and is triggered by enteroviruses, particularly enterovirus D68. And in the past 10 years, we have experienced 3 major outbreaks of such disorders in the United States. And those cases of acute flaccid myelitis has been observed also around the world in Europe and South America. There are other forms of infections that unfortunately I don't have too much time to pay attention that are very important to pay focus in the evaluation of patients. And those are the ones that are related with acute viral infections, particularly herpes virus simplex and other type of infectious disorder like West Nile virus that may produce acute form of myelopathy. Now, we still have, obviously, the large spectrum of other autoimmune mediated disorders and inflammatory disorders, and particularly multiple sclerosis, and particularly myelitis associated with demyelinating disease, that occasionally is the first manifestation of multiple sclerosis, and clinical isolated demyelinating syndrome is perhaps the most important one, and is one of the categories in the spectrum of inflammatory myelopathies that any clinician need to pay attention during the acute assessment of patients with myelitis. Granulomatous inflammation of the spinal cord actually is becoming a very interesting area of research, because this is a group of patients that evolve chronically and produce a very refractory form of inflammatory myelopathy. And many of these patients actually end up with the diagnosis of systemic sarcoidosis, in which the myelopathy or myelitis actually is the first manifestation of that disorder. And we will touch base about the myelitis associated with sarcoidosis. But the next spectrum of disorders is the one that I like to make emphasis today, is the spectrum of spinal cord disorders that frequently are misdiagnosed as, in quotes, myelitis or transient myelitis, but end up being not necessarily an inflammatory disorder, but a vascular myelopathy, either in the form of acute strokes and vascular myelopathies associated with venous hypertension, such as dural AV fistulas or arteriovenous malformation. And the main message for the new generation of neurologists is, please pay attention to these disorders. We are misdiagnosing these disorders in a very difficult way, that patients actually are mistreated and end up with significant amount of disability because the misdiagnosis. And the other spectrum of non-inflammatory disorders that unfortunately don't have too much time to discuss is disorders that are associated with metabolic disturbances, or disorders that are associated with structural abnormalities of the spine, particularly spondylotic myelopathy. But let's go back to our experience, and this is where I like to make emphasis. We took a look of our experience in the past 20 years, and we took all our referrals to our center who were patients that were diagnosed or admitted to our institution with the diagnosis of transient myelitis. And we put basically all of those patients under the microscope of a more precise etiological diagnosis. And to our surprise, as you can see in this graphic of approximately 1,193 patients, almost 35% of the patients didn't have any form of inflammatory myelopathy or myelitis. So many of these patients actually came to our center with diagnosis of myelitis, and some of them may have been already treated as myelitis. So after a very careful assessment of this patient population, actually, we concluded that many of them actually didn't have inflammation in the spinal cord, but rather had other pathologies like spinal cord strokes or dural AV fistulas, or even structural abnormalities in the spine that led to the development of myelopathies that were mostly spondylotic myelopathies. And as you can see also in a minor percentage, other type of abnormalities such as tumors or metabolic myelopathies. But the most important message here is when you are evaluating a patient with an spinal cord disorder that you are suspicious about the presence of myelitis, you need to pay attention that there are no other factors different to inflammation or infection or autoimmunity that may influence the spinal cord disorder, particularly vascular or metabolic or structural abnormalities. In the spectrum of inflammatory myelopathies, as you can see, when we use the term transient myelitis, actually we are putting in the basket many patients with a very diverse group of etiologies, particularly demyelinating spinal cord disease, or a neuromyelitis spectrum disorder, or sarcoidosis associated myelopathy, or other type of myelopathies that are associated in some way with inflammation triggered by infection or rheumatological disorders. So this is the emphasis that we are paying attention now, is the emphasis in establishing a better etiological diagnosis. And in that way, obviously, that will facilitate a better management and better treatment of this patient population. So take-home message is almost a third of the patients that are diagnosed in quotes with transient myelitis end up having no transient myelitis or myelitis at all, and they have other pathologies like vascular myelopathies or other mechanical associated myelopathies. So what is the role of a clinician when the clinician encounters a patient with a spinal cord disorder suspicious to be a myelitis or myelopathy? And the most important role of the clinician is to recognize very quickly the symptoms that may be associated with myelopathy. I mentioned this because we pay a lot of attention to possibility of other etiological diagnoses like Guillain-Barré. And the distinction of Guillain-Barré and myelopathy sometimes may be challenging during the acute phase when we are evaluating those patients in the emergency department. So it's important that the clinician recognize quickly what are the patients that may experience myelopathy versus some of the patients that experience acute evolving peripheral neuropathies. So one of the key elements of that recognition is to listen what the patient is describing. And unfortunately, we pay a lot of attention to imaging. Many patients in the ER, we are called to the ER because the ER attending or the ER clinician basically get an MRI, get a report of something going on in the spinal cord, and immediately that patient is diagnosed in quotes with transient myelitis. But we don't listen to the patient, and we need to basically to establish a very good conversation with the patient to identify many elements of the clinical history, particularly the evolution of the symptoms, the characteristic of the symptoms, and particularly to be able to establish a more precise clinical profile of what is going on with that specific patients. And I always emphasize to our residents that it's extremely important to characterize the time profile and the evolution of symptoms. What is that? So it's basically understanding, yes, you have a myelopathy, you have a spinal cord disorder. Is that myelopathy evolving in a hyperacute way? Is this a myelopathy that started in a matter of minutes and established and reached an nadir in a matter of 2 hours or 3 hours? Is this a myelopathy that is evolving in the past few days, or is a myelopathy that has been evolving for several days, weeks, or even months? So establishing this temporal profile is going to be extremely helpful for identification of etiological factors. Now, one thing that is always important in clinical medicine is the summary of an equation that involves different factors. And I always emphasize it's extremely important to bring the equation of spinal cord disorders to the table when we are analyzing a patient with a suspected myelopathy. So what are the elements of the equation? So the element of equation involves several factors. the age and profile of the patient, the time profile and evolution of the symptoms, the lesion localization. Is a patient experiencing predominantly a white matter disorder or gray matter disorder? What is the extension of that disorder? So there are many elements in these equations that the clinician need to be aware before committing to a more specific etiological diagnosis. It's very easy to label a patient transient myelitis. It's very difficult to achieve an etiological diagnosis. But we are in the 21st century. We need to basically go and characterize better what is the cause of the problem in the spinal cord. So again, the main message, particularly for the residents, is we need to pay attention to the patient profile. Are there specific characteristic risk factors in that patient to have a myelopathy? What is the temporal profile of symptoms? What is the topography of the lesion based on the neurological exam or MRI? And that is going to help us to have a better understanding of etiological factors. So when you are encountering a patient with myelitis versus myelopathy, you need to understand how you are able to differentiate the etiology of that disorder. And again, these are the major elements: just a very good clinical history, a very good neurological examination. And yes, the MRI is extremely helpful because the MRI is going to characterize the extension of the lesion, the topography of the lesion, the spinal fluid analysis is going to be very helpful as well. But at the end, what is going to provide you with a more definite and precise diagnosis is the combination of all of these elements in the equation of the diagnosis. So when we are going to examine this large population of patients, and we like to characterize if this patient fits in the category of a demyelinating disorder, or in the category of sarcoidosis associated myelopathy, or is this a dural IV fistula, we need to think about all of those elements. So that is exactly what we did a few years ago. And this is a work by one of our fellows and our group. And this was published in 2018 and characterized approximately 457 patients that came to our center with the diagnosis of transient myelitis. And again, what we put under the microscope of analysis was what were the difference when we established etiological diagnosis? What were the factors, the categories that contribute to the differentiation between inflammatory myelopathies, a stroke of the spinal cord, or dural AV fistula, or spondylotic myelopathy, or other type of myelopathy? So as you can see, this is a very large group of patients with different characteristics. And we were very interested in defining where were the major biological markers that differentiate myelitis versus other form of myelopathy, like vascular myelopathies or structural and associated myelopathies. What we found is that when we were trying to characterize myelitis versus acute strokes or vascular myelopathies, a very important element was the identification of factors in the patient population. For example, patients with underlying rheumatological disorders or underlying autoimmune disorder, actually that's a very important factor that help us to establish mostly diagnosis of myelitis. Interestingly, the temporal profile of symptoms was extremely helpful to differentiate myelitis versus strokes of the spinal cord. And you know this from your practice, and you know this very well when you are interacting with patients that have acute onset of neurological symptom myelopathy that evolve in matter of minutes to 2 or 3 hours. Those are the patients that we are highly suspicious to have vascular events, strokes of the spinal cord, and that show up in our statistical analysis to be a factor that is extremely helpful to differentiate between myelitis and acute vascular events. The chronicity of the of the clinical syndrome actually was tilting the patient population to be diagnosed mostly as myelitis. In other words, myelitis have tendency to have a temporal profile that is mostly characteristic to be days and weeks. So the chronicity of those and the slow progression of those symptoms during the acute and subacute phase actually is more characteristic of myelitis rather than stroke. There was one factor in the presentation that was very interesting, and I basically encourage you to analyze the pattern of strokes. Patients that experience stroke actually experience excruciating back pain that was very acute onset back pain. In other words, many of the patient population with acute vascular events, actually one of the characteristics in presentation, in addition to the weakness or other type of signs, was a very acute onset of back pain, either upper back pain or lower back pain in the case of lumbar strokes. But this is an interesting symptom that characterizes very well patients with acute strokes. In the case of vascular abnormalities that evolve chronically, that are very frequent, particularly in older people, as in the case of dural AV fistula, obviously age was a factor, and this factor was in favor of people that were above age 60. And again, this is an interesting factor that helps. Now, the other thing that was very interesting to observe is patients with dural AV fistulas and arteriovenous malformations were prominently male patients over age 60. So this is actually a very clear risk factor for identification of patients with vascular pathology of the spinal cord, particularly associated with dural AV fistula. Now, other elements in the presentation of symptoms was that many patients with these vascular abnormalities worsened symptoms during exercising or had more prevalence of bladder and bowel dysfunction. And many of these patients actually evolved with a chronicity of symptoms that was very characteristic. Now, age is an interesting factor when we analyze patients with myelopathies. And this is a recent work that has been submitted for publication. This is an analysis of over 1,193 patients in which we analyze the age in terms of the pathologies associated with etiologies. And as we see here in these histograms, the myelinating disease have a tendency to concentrate between ages of 30 and 40s, while other pathologies like strokes actually have a bimodal distribution. A stroke of the spinal cord, in our experience, actually had a very interesting bimodal distribution in which we saw a cluster of patients in young age and a cluster of patients, obviously, after age 50 and 60. And this is interesting because the presentation of spinal cord stroke is very different. And you need to pay attention. Patients with within the pediatric spectrum, actually, they have strokes. In other words, kids have strokes, and you need to pay attention to that and be aware about that. Interestingly, patients with dural AV fistulas or vascular abnormalities associated with venous hypertension actually have tendency to be older and with presentation mostly after age 50 or 60. And the same happened with a patient with a structural spondylotic myelopathies that have tendency to be older. In contrast, patients with infection-associated myelopathies have tendency to be younger. And this is actually biased by the presence in our case population of a lot of patients with acute flaccid myelitis. And this is probably it reflects bias of a referral because our center is very well focused in acute onset myelopathies, including acute flaccid myelitis. So What about the temporal profile? The temporal profile is extremely helpful to characterize some patient populations. So as I mentioned before, inflammatory myelopathies have tendency to be acute and subacute. Vascular myelopathies have two patterns of distribution. There is the group of stroke patients that are characteristically hyperacute, and the group of patients that are chronic evolving, and this basically comprises all the patients with dural AV fistulas and chronic evolving vascular abnormalities. Now, as you can see in this graphic, many of the patients with demyelinating disorders or other patients with neuromyelitis optic spectrum disorders have characteristically an acute or subacute pattern of evolution, in contrast with sarcoidosis associated myelopathy that have predominantly a subacute and chronic evolving profile, the same as rheumatological associated myelopathies that have tendency to be mostly chronic. Now, this is basically the summary when you are analyzing patients with myelopathy. So think about that many patients with hyperacute symptomatology, symptoms of myelopathy evolving from minutes to few hours. Many of them are either acute vascular myelopathy, or if you are dealing with children, you need to think about the possibility of acute flaccid myelitis. But if you are thinking about acute symptoms, several hours to few days, or subacute symptoms, you need to think about the presence of myelitis in the spectrum of NMO or MOGAD, or spectrum of autoimmune associated myelopathies. Or if the pattern is a relapsing remitting pattern, you need to think about multiple sclerosis, demyelinating disease, or neuromyelitis optica. It's very clear that many of the sarcoidosis associated myelopathies evolve chronically, as well as many patients with chronic vascular myelopathies and spondylotic myelopathy. So keep in mind that the temporal profile of symptoms is in many ways very helpful to establish some presumptive etiological diagnosis. What about other elements of the clinical assessment? We are talking about magnetic resonance imaging as well as spinal fluid. So MRI actually is extremely helpful. MRI is one of the tools that have revolutionized the analysis of spinal cord disorders. So what are the most important aspects when we are analyzing magnetic resonance images in patients with spinal cord disorders? The most important is the assessment of pattern of distribution of lesions. The pattern of involvement is a gray matter or white matter lesion. Is this lesion that is focal or multifocal? And the extension of the lesion is extremely helpful. So longitudinal extensive lesions are very characteristic in some pathologies like neuromyelitis optica, MOGAD, or even vascular abnormalities like dural AV fistulas. The pattern of enhancement is also very helpful. It's extremely important to analyze not only the distribution and topography of the lesion, but also the presence of focal or peripheral enhancement, meningeal enhancement, or even the pattern of root enhancement. And obviously, and I always encourage every patient with a myelopathy need to have a brain MRI, and particularly because MRI is going to be extremely helpful to rule out other inflammatory associated pathologies of the nervous system, like demyelinating disorders, or even in the spectrum of autoimmune disorders, MOGAD or neuromyelitis optica. Having an MRI is very helpful in the differential diagnosis. So I will encourage you to pay a lot of attention to the focality of the lesion, the characteristic of the distribution of that lesion, differentiating gray matter, white matter involvement, and the pattern of enhancement. What about spinal fluid? The spinal fluid actually is very valuable. Spinal fluid is the best window for examining the physiology of what is going on in the spinal cord, because it provides an information about the amount of cells, proteins, but importantly for us, provide information about the immune status in the central nervous system, particularly because we are able to test oligoclonal bands and the immunoglobulin index, or we are able to test potential etiological factors like viral disorders or autoimmune disorders. In the next several years, very likely we are going to introduce more assays to assess spinal fluid, particularly spinal fluid cytokines, and assessment of neurofilament light change protein. And those are actually going to give us elements of prognosis. But importantly for us in the clinical setting, every time that you do a spinal tap, please include oligoclonal bands, please include the analysis of immunoglobulin index, because as a part of the clinical assessment, it's extremely important to determine if the myelopathy that you are evaluating is associated or is not to immunological disorders like multiple sclerosis or MOGAD associated disorders. So in the analysis of our patient population, what we found is that when you put magnetic resonance imaging factors, one thing that obviously characterizes very well myelitis is the presence of gadolinium-associated lesions. However, I need to remind you that the strokes may enhance after several days after the initial ictus. In other words, if you have a spinal cord stroke and you do the MRI the first 24 hours, very likely the lesion is not going to be enhancing. But 5 days later or 10 days later, that lesion is likely going to enhance. So just keep in mind that the pattern of enhancement depends also of the stage in which you are evaluating the specific patient. The same happened with the distribution of the lesions. Patients with lesions that are characteristically located in the posterior region of the spinal cord frequently are patients with inflammatory myelopathies or myelitis. What about the spinal fluid? Spinal fluid is extremely helpful. Again, the presence of pleocytosis is extremely helpful for the characterization and diagnosis of myelitis. The presence of oligoclonal bands is extremely helpful for that characterization. So keep in mind that those are elements that are going to help you to establish a better etiological diagnosis. So let's examine briefly some of the main aspects in inflammatory myelopathies to summarize inflammatory myelopathies. Inflammatory myelopathies, in our experience, fit in three major categories: demyelinating disease, neuromyelitis optica and MOGAD associated disorders, and sarcoidosis associated myelopathies. And this is important again, because remember our initial historical slide. So many patients with myelopathies back in the 20th century, at the beginning of the 21st century, were diagnosed with multiple sclerosis. But in reality, at the present, only 20–25% of those patients are patients with demyelinating disease. However, it's extremely important for you as a clinician to evaluate carefully a patient with new onset myelitis, because you need to characterize if that patient may have or may not multiple sclerosis, and having a good characterization of the clinical profile, MRI and spinal fluid is going to be very helpful. One thing from practical point of view, we analyzed, and this was published last year by our group, we analyzed in our patient population what is the evolution of myelitis to our demyelinating disease. So we analyzed a total of 331 patients suspected to have idiopathic demyelinating disease. What we found was that in general, when we are evaluating those patients and we introduce either MRI or oligoclonal bands as a way to analyze the potential outcome of those patients, it was very clear that 25% of those patients that were associated with isolated myelopathy or myelitis, inflammatory myelopathy, evolved to multiple sclerosis based on the criteria by McDonald. So the conversion was seen particularly in patients with short segment myelitis, again, very small focal or multifocal myelitis, And also, it was particularly important in patients in which there was presence of oligoclonal bands. So in other words, if you have a patient that you are examining acutely, and that patient has a very small lesion, like is shown here in this MRI, and that patient has oligoclonal bands, the likelihood of evolution to a demyelinating disorder is in the range of 32% risk or possibility that that patient is going to convert to a demyelinating disease. And again, many times, as you can see in this figure, if you combine MRI as well as oligoclonal bands, the likelihood of conversion is going to increase more dramatically. So keep in mind that when you are evaluating these patients, that initial characteristic MRI and the spinal fluid oligoclonal bands is going to be very helpful. Now, I'm going to mention briefly sarcoidosis, because sarcoidosis is one of those inflammatory myelopathies that, rather than evolving acutely, present as a chronic evolving and very refractory myelopathy. In other words, is one of those myelopathies that is very difficult to be treated with just IV methylprednisolone. So those patients actually have a more aggressive disease, frequently present as an isolated myelopathy, and frequently is also the first manifestation of systemic sarcoidosis. In other words, when you see longitudinal extensive myelopathies that are evolving chronically, think about the possibility of sarcoidosis and do a chest CT scan to evaluate sarcoidosis. And if you find hilar lymphadenopathies, you are obligated to do lymph node biopsies to define if that patient has or doesn't have any problem with sarcoidosis. And you need to treat these patients aggressively because they evolve with different patterns of spinal cord disease, longitudinally evolving chronic inflammatory lesions, or they have patchy disease, or they have frequently leptomeningeal and peripheral disease and root enhancement that is very aggressive and produce a lot of neurological disability. Many of these patients have cervical spinal cord disorders. Frequently, the location of the longitudinal extensive myelopathies is in the cervical spinal cord, some of them also in the thoracic spinal cord. Patients with short-term effective myelitis are frequently patients with cervical cord involvement. And there is a very interesting group of patients in which most of the lesions are in the thoracic region, and those are associated with anterior cord involvement, particularly when they are associated with discal degeneration. So keep in mind that neurosarcoidosis and sarcoidosis is a very aggressive form of chronic myelitis, and frequently requires long-term treatment and immunosuppression. There are some signs that are very typical for identification of these disorders, like the trident sign that was identified by our colleagues at the Mayo Clinic. Now, let me touch bases briefly about other pathologies that are non-inflammatory. I'm talking about the non-inflammatory myelopathies. I'm going to mention briefly a spinal cord infarction, dural AV fistulas, and structural myelopathies. Briefly, remember that spondylotic myelopathy, myelopathies associated with compression due to discal pathology, frequently mimic myelitis because the spinal cord is very swollen and even edematous and with enhancement. And even after surgical procedures, there is residual damage of the spinal cord. Occasionally, some of these patients come to our clinic with the diagnosis of transient myelitis or myelitis, and actually, this basically reflects the damage of the spinal cord due to the chronicity of the compression of the spinal cord. So please be aware about those cases. Don't diagnose those as myelitis because frequently there is clear etiological factor that is the mechanical compression. But I'm going to spend the last 5 minutes talking about vascular myelopathies. Importantly, strokes of the spinal cord have a very important role in spinal cord disorders in children and in adults. And spinal cord disorders, particularly those stroke of the spinal cord, have a very characteristic picture, acute onset of symptoms. Unfortunately, at the present, we don't have a very clear nomenclature, and we don't have a clear diagnostic criteria for vascular myelopathy. We have suggested in the past that we need to define vascular myelopathies in a combination of clinical elements, MRI, and spinal fluid. And I invite you just to review some of these papers in which we examine those potential ways to characterize structure of the spinal cord. But I like to emphasize a little bit on the anatomy. Remember, we have a very exquisite vascular supply to the spinal cord provided by many arteries and blood vessels. So you can imagine that the spinal cord is very susceptible to a lot of pathologies, either in the cervical region, thoracolumbar region, or lumbosacral region. I'm going to mention a little bit of the anatomy. So the major territories in the cervical cord are basically territory supplied by vertebral arteries, and is very characteristic for pathologies like vertebral artery dissection to produce cervical cord disorders. However, there is another artery that is very important, is intersegmental artery of von Haller, that is providing blood supply to the upper portion of the thoracic cord, and the ankylosis artery that is providing obviously supply to the lower portion of the thoracic and lumbar cord. Pay attention to the three major territories: the territory of the vertebral arteries, the territory of the von Haller arteries, and ankylosis artery, because eventually you are going to deal with a combination of vascular abnormalities that occasionally may mix also with some blood venous abnormalities, because the spinal cord has these exquisite vascular supplies and vascular drainage. So what you are going to see in patients with some of the pathologies associated with vascular lesions are typical and occasionally very characteristic lesions. So you are going to see mostly gray matter involvement, and you are going to see also intrinsic watershed zone regions in which the gray matter is very susceptible to ischemia. Is going to be susceptible to ischemia, particularly in the anterior horn of the spinal cord or in the dorsal horn of the spinal cord. Those are the territories with more susceptibility to hypoxemic and ischemic lesions. But you can see in MRIs a very wide spectrum of lesions. You can see the most characteristic lesion in which the anterior horn is wiped out completely. You see these all eyes or snake eyes in the MRI axial sections, or you can see even other type of lesions, including lesions in the dorsal horn or lesions in the entire gray matter, or even asymmetric lesions like lesion affecting only one portion of the spinal cord. Unfortunately, I'm running out of time, but I like to make emphasis in two major things from practical point of view. When you are establishing a diagnosis of myelopathy, you are going to define the etiological diagnosis because you are in need to treat the patient. So when you are diagnosing myelopathy, it's extremely important to establish this etiological diagnosis, because either you are going to take the route of treating the patients with immunological treatment, like in the case of inflammatory myelopathies, in which you use IV steroids or oral steroids or plasma exchange or immunosuppression, or you are going to take the route of ischemic myelopathy. It's extremely important to identify ischemic myelopathy, because if you identify strokes, you need to treat the stroke. You need to treat the risk factor for the stroke. You don't need to treat this patient with plasma exchange or immunosuppression. Or if you identify a chronic evolving lesion associated with dural AV fistula, you are going to treat the fistula. And this is important because in the past 5 and 10 years, we have introduced a lot of new treatments in the management of inflammatory myelopathies. We are introducing B-cell therapies, we are introducing complement inhibition therapies, TNF-alpha inhibition in the case of sarcoidosis, or other type of immunosuppressive regimens. I don't believe is a good idea to start treatment right away without having a very good etiological diagnosis, and eventually missing the possibility that some of the patients with chronic lesions like dural AV fistula or strokes are going to be treated with some of these immunological mediated therapies. So be careful with the assessment of patients with myelopathy, and the message is try to be very precise in the identification of etiology, and keep in mind all of this group of etiologies when you are analyzing patients with any type of acute, subacute, or chronic evolving myelopathy. So in that way, the patient will benefit from a better treatment and a better outcome. So keep in mind that diagnosis of these spinal cord disorders involve an equation in which you need to be the main mathematician. You need to be the person who is going to basically resolve or solve the equation of this complexity. I like to finish saying that all of this work is the work of a lot of people that in the past 20 years have been contributing to the Myelopathy Center at Johns Hopkins. It's not only neurologists, our rehabilitation specialists, our neuroradiologists, our interventional radiologists, but the most important is the passion to identify problems in the spinal cord and get patients in a better situation and improve the health and quality of life of those patients. So thank you so much again for the invitation, and happy to answer some of the questions that you may have about this. I ran a little bit out of time, but I hope that you have some questions after all of this description.
Thank you, Dr. Pardo. That was an excellent presentation. Again, thank you for this marvelous. The microphone is open for questions. So any of the participants can go ahead. You can write also questions in the chat if someone wants to do it.
One thing that probably I will encourage you, and you are going to encounter this, and probably you already encountered this in the past 2 years, and a good example that we are seeing right now in COVID-19 is a lot of people are jumping to diagnose COVID-19 associated myelopathies. And actually, we have encountered a very diverse group of spinal cord disorders. And I will make sure all the time that we pay a lot of attention. I'm going to show you, I don't know if there is any specific question, I'm going to show you this very fascinating patient that I actually we saw recently. This is a woman in early 20s who developed cognitive, visual, and gait disturbance almost 40 days after experiencing COVID-19. And this patient actually was evaluated very quickly by one of our colleagues in another state. And the patient was found with this brain and spinal cord MRI that clearly show evidence of a longitudinal extensive lesion. And the lesion was enhancing with gadolinium, and there were brain abnormalities. What do you think happened? Any volunteer from the resident group? Now I'm switching my role, so I'm asking the questions. Is this COVID myelopathy? Is this COVID ADM? Is this something abnormal associated with COVID? The spinal fluid analysis was normal. Let me show you additional information. The patient with these findings was treated with IV methylprednisolone, plasma exchange, IVIG, and didn't get better. She went to rituximab, And guess what? When they did a better assessment, they found that vitamin B6 was low, vitamin B12 was okay, borderline low, but methylmalonic acid was over the roof. What do you think is happening here? This is the OCT.
B12 deficiency.
Repeat that again. Somebody answered, but I didn't hear it well. Okay, so this patient had a combination of optic nerve pathology, spinal cord pathology, white matter disease, didn't respond to any treatment, and blood workup when she was evaluated in our center showed this dramatic increase in methylmalonic acid. This is a case of cyanocobalamin deficiency. Actually, this is not a pure vitamin deficiency. This is a cyanocobalamin deficiency that is a genetic disorder, and this patient actually very likely COVID-19 didn't produce this. COVID-19 unmasked the cyanocobalamin deficiency that she probably had experienced, and the illness and infectious disorder likely unmasked that disorder. So I wanted to show this as an example that every time that you cross with this type of patient, you need to be clearly analyzing the whole profile and spectrum of possibilities. And this is, in many ways, I mean, we lost a lot of time when this patient was treated with all of these things without having clearly an inflammatory pathology. Okay, thank you so much. I don't know if there is any question or any other comment.
Yeah, Dr. Pardo, there's a question on the chat. So there's a question that says, what do you think about anti-CD20 antibodies in MS and other myelopathies? And are they helpful in both or have more side effects?
So we use a lot of B-cell therapies in patients with aggressive form of demyelinating disease. I always state that anytime you cross with a patient with a demyelinating disease in which the spinal cord is involved, that's a factor of disability. And in those patients, actually, I have tendency to be aggressive, and I frequently use B-cell therapies to avoid that that patient keep progressing and keep having damage of the spinal cord. So if your question is if this is the way to go, yes, it's a very frequent approach that we use to treat patients with demyelinating disease that involve the spinal cord.
Thank you, Dr. Pardo. There is another question from one of our viewers. Oh, sure.
Yeah, this is Nick Parmitsakis. Thank you, Dr. Pardo. That was a very nice presentation. And I think the takeaways that we need to obviously look for other etiologies, in particular ischemic. I'm a stroke neurologist, and I have to admit that infarction of the cord, it's something that we rarely see, and typically with maybe some relate to some procedures, let's say major cardiac, aortic arch, etc. So the question here is, what is the best technique to diagnose? Because as far as I know, diffusion sequences on the spine MRI are not really too revealing. Maybe I'm mistaken, and you can you know, elucidate that point a little bit better. The best diagnostic approach when you suspect it.
Yeah, it's a very good question, and the reason you are not seeing many of these patients is many of these patients don't go to the stroke service, and many of these patients go to the ER, and frequently many of these patients are diagnosed with myelopathy, myelitis, and treated as myelitis, and many months later it came out that this is clearly a stroke. So you are right. DWI assessment in the spinal cord is tricky. Is technically challenging. It's not like brain DWI. You may get good results if you are evaluating the cervical cord, because the cervical cord is bulky, is larger. The thoracic spinal cord is very bad for DWI assessment. If you are dealing with a patient within the first 72 hours of a myelopathic syndrome, you will be very lucky to see this, but after that it's very difficult, because then the patient is going to have inflammation associated, it's going to have enhancement, and the DWI is going to disappear. This is actually an example of one of our patients with a vertebral artery dissection. It's very clear that this patient came to us actually with a diagnosis of myelitis, but retrospectively, when we analyzed this patient, actually it was very clear that this patient had an artery dissection, particularly because, number one, there was not too much evidence of enhancement, and number two, most of the lesions was centered in the gray matter, and number three, spinal fluid was negative. So when you have a patient that you are evaluating for an acute or hyperacute myelopathy and the spinal fluid is normal, that's a huge flag that that is not myelitis. And that is the type of patient that I will encourage you to investigate for a spinal cord pathology associated with ischemia. There are other forms of analysis. For example, we frequently encounter cases like this, in which we see very small localized lesions, in this case, in the posterior region of the lumbar spinal cord. And we always claimed, oh, this is a myelitis. But when we analyze these patients more carefully, we encountered that this patient have pathology like associated with compression of intersegmental arteries, even associated with anterior discal structure or compression of blood vessel structure. So just keep in mind that sometimes the key is the clinical profile. Hyperacute symptoms and spinal fluid that is normal, that's a flag. That's not myelitis. Look for strokes, vascular abnormalities, or other problems, particularly if you are dealing with an older patient, or you are dealing even with a young patient in which the change happened hyperacutely.
Thank you very much.
Dr. Pardo, I think like we are running out of time, but I want to thank you again for this presentation. It was very wonderful, and I think like if there is any more questions, we're gonna like send you some emails again. But like thank you again, and I think it's all for today.
Great. Well, thank you so much again, all of you, for participating in the grand rounds. And again, anytime that you have questions about myelitis, myelopathy, I'm very happy to interact with you in it. So let me know. Thank you.
Perfect. Thank you. Had a good day.
Same to you. Bye now.
Thank you to all the participants.